are all related to the first generation. Hence, there's a need to improve upon that. Hence, they are the second generation compounds that are coming on. Okay, so this is a summary. First generation, D2 better than 5-HT2. Second generation, either equal or 5-HT2 better. And so, first generation more likely to have EPS, hyperprolactinemia. Second generations are less likely to have that. But by aiming at 5-HT, you have other effects, right? So because 5-HT is involved in other things. So weight gain is an important issue. Okay, so let's talk about the general mechanism of action of all of the antipsychotic compounds. All of the FGAs and most of the SGAs would block the D2 receptor. Even though for the second generation, the affinity to the 5-HT2 are better than the D2, many of them still block the D2, right? So they will still block the D2. And then also for the serotonin antagonism, most of the second generation would work mainly on the 5-HT receptor, especially the 5-HT2A receptor. Some of the first generation would also work on that too. It's just a relative event. But just like Dr. Emmer's class, there are always exceptions. So these are the exceptions. Clozapine actually doesn't block the D2 receptor. But it has a high affinity for D1, D4, 5-HT2 muscarinic, and alpha-adrenergic receptors. Therefore, you can immediately imagine there are a lot of potential adverse effects relating to all these receptors. And then aripiprazole, which is Abilify, it is a partial agonist to the D2 receptor as well as the 5-HT1A receptor, and is an antagonist of 5-HT2A receptor. So a partial agonist, by definition, is also a partial antagonist, right? We'll talk about that. So by blocking 5-HT2A and also partially blocking D2, Abilify is used for the antipsychotic drug. And quetiapine is a weak compound for both the D2 and 5-HT2A. For being a weak compound, so you would have a less frequency of the EPS or hyperprolactinemia events. Also is less likely to produce weight gain. But then you need to use more drug because it's a weak compound. So all these are trade-off, okay? So these are the general rules. For the important points as an antipsychotic effects, all of the drugs are equal in efficacy. What does that mean? That means that if I give enough amount of the drug, then all of them can reach the same level of protection to the patient, okay? If you are trying to decrease the hallucination, delusion, then as long as you give the high enough amount, then all of the drugs will work. So then all you need to worry to wait is the adverse effect, right? Or the other factors. And all of the drugs will reduce the positive symptoms by blocking the D2 receptor in the mesolimbic system. The SGA, second generation, but not necessarily the first generation, can reduce the negative symptoms to some extent. Some work, some don't work as well. So the specifics, I cannot tell you that, if this is apins, if they are idones, then always work. No, it's not always, okay? And then by blocking the D2 receptor, many of these drugs are also having anti-emetic effects. So they can actually suppress the nausea and vomiting response in the body that is induced by something else, let's say by chemotherapy induced, okay? So the reason is that the vomiting reflex is mediated by the vomiting center in the medulla, okay? And some of the chemicals, when you eat something that disagree with your stomach, it goes to the travel in blood and goes into the brain, to an area that's called chemotrigger zone, right? And then that can send signal to the vomiting center. Of course, there are other ways to induce that. And the chemotrigger zone and the vomiting center is believed the signal to vomit is mediated by the dopaminergic nervous system. So if you can block that, you can also work as an anti-emetic to prevent nausea and vomiting. And in fact, many of the drugs that we talk about today are approved as an anti-emetic, except aripiprazole, Abilify, because it itself is a partial agonist of the D2 receptor. So it actually doesn't work very well in blocking it. And itself, if you give high enough dose, it might also cause nausea and emesis because it also triggered work on the activated dopaminergic system in the chemotrigger zone. Okay, so that's the reason of it. Okay, and also we mentioned that by blocking the D2, you are blocking the nigrostriatal system of dopaminergic, as though you are inducing Parkinson's disease, right? You are blocking the D2 system, just like in Parkinson's disease, the patients are lacking the dopaminergic system. So, so these are the typical idea. If you block some degree of the receptor, you can have an antipsychotic effect. Too much, then you become EPS. And because the SGAs, they typically are not as potent for the D2 receptors, so they have a lower incidence of EPS. And then the same idea is the hyperprolactinemia. Okay. As Dr. Emmett already mentioned, that many of these drugs also will talk to the other receptors, such as the muscarinic receptors. So, such as chlorpromazine or thioridazine, and then the SGA's clozapine, which is a very promiscuous compound, olanzapine, so the second generation, they will also block the muscarinic receptor. And therefore, you have all these anti-muscarinic side effects. So sometimes constipation, urinary retention, those are very, very severe and uncomfortable side effects. There are some suggestions that the anticholinergic effect may actually reduce some of the D2-related EPS effect. And some of the drugs also block the alpha-adrenergic receptors, therefore will cause orthostatic hypotension because the blood vessels cannot contract well. And then some of them will block the H1 histamine receptor, therefore make you sleepy. So sedation is a concern, and sexual dysfunctions could due to the blocking of so many different receptors. Okay, another eye clicker, just to keep you awake. Ten more seconds. Okay. Excellent. That's the correct answer. So we talk about D2 antagonism, 5-HT2A antagonism. Now it's very important for you to keep in mind agonist or antagonist, right? Because for Parkinson, you want agonist. For this, you want antagonist. And then you will also learn that to help depression, you want 5-HT agonist, okay? So you need to put the different drug treatment mechanism of action into the appropriate bin. All right, As I mentioned, that if you give the correct dose, they all have the same efficacy at the end. So drugs that are less potent, then you just need to give more of them. So these are the list of drugs from less potent to more potent, how tight they bind to the receptor. As long as you give the right amount, high enough, comparing to the more potent drugs, then they will work. They would produce the same efficacy. Dr. Emmett also mentioned some of the drugs are long-acting injectables, injections, and he mentioned that you simply attach a fatty acyl chain to the hydroxyl group. Some of these two are first generation, and then these three are the second generation. So for the patients, they just cannot take pills sometimes because the behavior, or they don't believe that they have the disease. So then you do the injection. It is very important that because the compounds at this point, you add a long fatty acyl chain, the molecular weight of that is significantly higher than the fluphenazine itself. So 1 milligram of fluphenazine decanoate is not the same in terms of molar concentration versus the fluphenazine alone, okay? Because now you increase the molecular weight. So you need to calculate the conversion from oral to injection in order to give the same amount of molecule, of the active molecule in the patient, okay? So that's very important. Okay, so let's talk about 6 of the compounds on the list because I just want to point out some of the special feature. Chlorpromazine is the first ever antipsychotic drugs, so it is the first generation compound. In addition of being approved to treat schizophrenia, it's also control nausea and vomiting by blocking the D2 in the chemotrigger zone. And then also restless apprehension, manic phase of bipolar disorder, intractable hiccups, and then also the aggressive behavior in children. So all this may be related. As expected, so this compound, as Dr. Emmett already mentioned, is quite dirty. It interacts with many receptors. D2, adverse effects, alpha-1, adverse effect, histamine, adverse effect, okay? And then also it has a neuroleptic malignant syndrome. So this, when you give the drug for a relatively long time, then the patient might be cause extremely rigidity, fever, unstable blood pressure, raised white blood cell, creatine, phosphokinase, and which may be even fatal. The exact reason is not very well known, but the idea is that maybe by continuously, chronically blocking the D2 receptor, the neurons are actually reacting to it. The neurons want to have some dopaminergic activity, so the neuron actually make more D2 receptor. Okay? Then you have this, that's a different thing, sorry. So this is maybe related to a sudden drop in the dopaminergic activity, okay? The treatment of this is simply injection of muscle relaxant, like dantrolene. And then, so is there a genetic predisposition? We don't know that. This compound also is known to have weight gain problems. But if you read the literature, there's not a lot of, in the original literature, there's not a lot of mentioning